I'd like to thank the organizers for allowing me the opportunity to speak to you all today. It's a real pleasure and a real honor to be here. As I said, I was here about 3.5 years ago when my son was about 1.5 years, 2 years old, and he just turned 5 as well. So I know how much happens in 5 years. So I wanted to congratulate all of you on a 5th year anniversary as well. Without further ado, I'll get started. As Marco mentioned, thank you for that wonderful introduction. I have a specialty in diabetes and kidney disease, both on the clinical side and also on the research side. And I should say, as part of that, while I'm giving thank yous, that I'd like to thank the Palo Alto Medical Foundation as well. I know they've been very generous in allowing us to use this room today. They've also been equally generous in allowing me to participate in kidney research that is beneficial for patients with both diabetes and kidney disease. So I thank them for that. So this is just a quote from a patient that I found was interesting. Let's go ahead and read it. For too many people like me, Banting's discovery of insulin, which happened way back in 1923, only allowed them to live just long enough to develop blindness, renal failure, and coronary artery disease. And this was really just in the context of a patient that had been noted to have very good sugar control and had done a lot to control his sugar, but was still suffering from some of the complications of diabetes that have been with us even since the discovery of insulin almost 100 years ago. This is actually a quote by Dr. Michael Brownlee. He actually gave the annual Banting lecture, which is given in honor of the discovery of insulin every year. And he was a noted researcher in the field, so even he struggled with this disease. So just an overview of the things I wanted to have the chance to go over for the next hour. I'm going to be talking about some general terms related to referral to nephrology clinic and terms that patients with diabetes and kidney disease that are introduced to these terms when they first find out about kidney disease. Then I'm going to be speaking about 3 other topics. One is diabetic kidney disease in the patients who are not on dialysis. I call that pre-dialysis. Also, I'm going to be speaking only very briefly about diabetes and kidney transplantation. I understand that about a year ago you all had a presentation by folks from Stanford on transplantation, so I've decided to limit my comments in that area. And then just a brief word about recent advances in diagnosis and treatment, so some hopeful things for the future. So just in general, who is the nephrologist? Is that somebody who's, we get this question a lot, actually. We are kidney doctors. We work in a renal clinic. We are often confused with urologists, which are the kidney surgeons, if you will. And we have all studied in the field of nephrology and hypertension. So that's sort of our 2 domains. We are trained in functional kidney diseases. So that means anything that affects all of the nephrons or all of the functional units of the kidney equally. We do not treat things like kidney cancer. That is something in the domain of the urologist. So if any of you, when we were first referred to a nephrologist, this is sort of our area of expertise. And as part of that, diabetic kidney disease is a major, major part of what we do. And you can query any nephrologist about that. They'll tell you that about 50% of the patients that they see, either in clinic or at a dialysis center, have diabetes and kidney disease. It is not uncommon by any means. Just some basic terms of the basic kidney functions. I think this is the question of what does the kidney do is the first question I get in clinic. It's because we don't really think about what the kidney does when you're growing up, when you become an adult, when you first develop diabetes. This term of the kidney and what it does doesn't really come up until all of a sudden a doctor might mention that you have kidney disease and you have to be referred to a nephrologist. So there are 3 things that the kidney does, and most of you, I apologize for any, if any of this is old, but I just thought I'd start with some first principles and move forward from there. So the kidneys clean the blood, and you'll often hear terms like glomerular filtration rate or GFR being quoted by a physician or patients. You'll hear terms like serum creatinine, and I'll go over what these terms mean in a sec. What I've shown here is a schematic of where the kidneys are located in the body. And you'll see here, right here in this dark red, is the aorta. It's essentially the main blood vessel that comes from the heart up here. My wife is a cardiologist, and she often chides me for the fact that I consider this the main part of the body rather than the part that concerns the heart, but that's a separate issue. So blood is pumped from the heart and comes down and circulates throughout the whole body, and part of that goes to each of the 2 kidneys. And then what I've shown here is just a cross-section of one of the microscopic areas within the kidney. This is called the glomerulus. So the name for it is a filter. And blood comes in here, and all of the small things in our blood get through the glomerulus. All of the salts, all of the ions, all of the water. And all of the bigger things in our blood, like cells that carry oxygen, or cells that fight infection, or cells that help us fight a clot, they don't get through the filter normally. Also, big things like protein do not get through the filter normally. And they just get siphoned off and go back into the blood, then eventually back into the circulation, back to the heart. But the stuff that gets through this filter, or through this glomerulus, then courses down from the outside of the kidney all the way down, and is essentially the waste products of the blood. And everything that our body needs gets retaken up back by the kidney and goes back into the blood. And what's left over is the urine. And that is collected in the 2 ureters that go down to the bladder, and then you pee that out. So the way that I describe how the kidney cleans the blood is not the way that one would intuitively think. The way that you would never clean your house like this. You would never go into your house, take all of the small things that you could carry, and put it out on the front lawn. And then everything that you realized you needed to keep, bring back into the house. And everything that you didn't need, you'd leave it on the front lawn. That's essentially what the kidney does. It just does it thousands and thousands of times a day. So it becomes more efficient. So basically all of the small stuff in our blood goes into the kidney. All of the good small stuff gets taken up back by the body. And all of the things that we don't need go into the urine. The other thing, oops, sorry about that. The other analogy that I think is helpful in this instance is that of an aquarium. Do any of you have an aquarium? They're kind of unpopular these days. But you all remember what an aquarium looks like. Oh, you're right. That's a better. You can imagine that everybody who has an aquarium that has fish in it has to have a filter, a big filter connected to that aquarium. And if you think of that filter connected to the aquarium as a pair of kidneys, and you think of all of the water in the aquarium as your blood, and all of the fish in the aquarium as the cells of your body, you know that when you have to feed the fish every day, and the fish naturally poop. And things that are in the blood or in the water of the aquarium have to get cleaned every day. And if you've ever let an aquarium go for more than a few days, you see what happens to the color of the water. And that's essentially the way that I think of what the kidney does, is that it gets rid of all the natural things that our body makes and that we eat in order to keep the water or the blood clean. So that's what I mean by cleaning the blood. And these terms, glomerular filtration rate, it essentially, this is the glomerulus, this filter in the blood. And it essentially asks or tells us how fast the blood is being cleaned, how effectively the blood is being cleaned. And so there's a number that's associated with this term of GFR. And you can imagine that the lower the number, the less effective the blood is being cleaned. So there's a unit to this measurement, but I kind of like to think of it in percent because I think it's more helpful. So if you imagine that one has 100% of their kidney function when they're younger, then this is the number that slowly declines over time. And patients with diabetes who are afflicted with kidney disease will have a faster decline of that rate over time. The other term that you'll hear is the serum creatinine. So serum creatinine is a fancy way of telling us something about how well the blood is being cleaned. Because creatinine is something that is natural in our blood, and it's not something that our body uses, but it's something that all nephrologists use to tell us what's going on in the kidney. So creatinine is a normal, harmless chemical that all of our muscle cells make and spit out into the blood every day. The thing about that that's useful is that it goes into the blood, it gets filtered through these filters, and then just passes its way freely, unobstructed, into the urine. So the level of the creatinine in the blood tells us something about how well the kidney is being cleaned. So the higher the level of creatinine in the blood, the less well the kidney is functioning. So nephrologists or patients might use this term or this term to describe how well kidneys are doing. If you have a high glomerular filtration rate, or GFR, kidneys are cleaning the blood effectively. If that number goes down, that means the kidneys are not cleaning the blood effectively. On the other hand, this number, which is the level of a chemical in the blood, it will go up when the kidneys are not cleaning the blood effectively. So a higher number means less kidney function, less GFR, less glomerular filtration rate. And that's one of the primary things that the kidney does. The other two things I think are just as important, but they often don't get as much attention. One of them is that the kidney really maintains balance. You've all heard the term, we are what we eat. But in reality, as far as a nephrologist is concerned, we excrete what we eat. So if one eats a lot of salt, the kidneys and the body are generally smart enough to figure out that we need to get rid of that excess salt into the urine so that we stay in balance from day to day to day. The same goes for potassium, the same goes for phosphorus, the same goes for sugar. And if the kidneys are damaged, and we know this by checking these numbers, this is a good surrogate for how well all of the functions of the kidney are doing. If the kidneys are damaged, then we aren't excreting what we eat, and things have a tendency to build up in the blood. So if one has kidney damage, that's the reason they can't take in too much salt, because their kidneys don't have the ability to excrete that excess salt. It builds up in the body and can lead to problems such as swelling and blood pressure, which many of you have probably experienced. The other function of the kidney is that it produces hormones that associate with diseases when those hormones are not there, that we don't normally think of when we think of kidneys. So things like epogen or erythropoietin, or the thing that Lance Armstrong is purported to be injecting himself with, is something that the kidney makes. It gets made all throughout the kidney, and it goes and tells the bone to make blood cells. So as the kidney gets more and more damaged, as the GFR goes down or as the creatinine goes up, one makes less and less erythropoietin. And so one can become anemic from kidney disease alone. The other main hormone... Sorry?
What did you say about anemia?
That if you don't make enough erythropoietin, enough of that hormone that tells the bone to make blood cells, then you can become anemic. Because in order to make blood cells, you need that signal. And if that signal is absent, then you don't make blood cells as well. The other hormone has to do with making the proper form of vitamin D that your bones need to stay healthy. And so not having enough healthy vitamin D causes bone disease. And so these are really the three functions of the kidney that can all be affected by diabetes. The cleaning of the blood, the maintenance of balance from day to day of all the things that we take in, and also the production of hormones. These three things apply to any form of kidney disease, and they equally well apply to patients with diabetes and kidney disease. It's basically the same. And diabetes is something that raises the blood sugar and affects both kidneys equally. So someone doesn't really have diabetic kidney disease on just one side, for example. It's something that affects all of the filters, all of these glomeruli in all of the kidneys equally. It doesn't spare any part of the kidney. So the next part I'd like to talk about is some more terms, but really to get into the meat of what diabetic kidney disease is. So there's three terms that I wanted to bring up as far as this is concerned. One is chronic kidney disease, which is a term that you've probably all heard of before. And I abbreviate that for the rest of the talk as CKD. The other is urine albumin excretion, or the amount of albumin, which is the biggest kind of protein, so the amount of protein that gets into the urine. And there is a little, you can have a little bit, or microalbuminuria, or a lot, or macroalbuminuria. And albumin is the main kind of protein in the urine. And remember when I was talking about the filters have only small little holes, so only the small stuff in our blood gets through. But we as doctors often check for protein in the urine, because if the filters are somehow damaged, then protein, which is normally too big to get through the filters and into the urine, in a damaged filter can squeeze through and then get into the urine. So this is another way, other than checking the blood tests and the GFR, that we can tell what kind of kidney disease is going on, especially in patients with diabetes and kidney disease. And the third term, these two terms are really interchangeable. One is diabetic nephropathy. I'll abbreviate that DN. And the other is diabetic kidney disease. These both refer to the type of kidney disease that one gets if you have diabetes, and that's the cause of the kidney disease. So this is a chart that is quite busy, but I just wanted to put it up there to give you guys a sense of how nephrologists view different kinds of kidney disease in terms of gradation, from mild to severe. So this has to do with chronic kidney disease, and the way that chronic kidney disease is defined is primarily by that GFR, or that glomerular filtration rate. Or in other words, just a numerical way of quantifying how well the kidneys are cleaning the blood. So if the kidneys are, and think of this in terms of percent, it's not exactly correct, but I think it's helpful to think about it. And you can imagine if a GFR is 100, that would be a good amount of GFR. So above 90 is very early stage 1 chronic kidney disease. And as the GFR goes down, so 60 to 90 is stage 2, less than 60, between 30 and 60 is stage 3, between 15 and 30 is stage 4, and less than 15, or anybody that has started dialysis or has gotten a kidney transplant, would be described as having chronic kidney disease stage 5. So this is how we segregate patients based on the severity of the kidney disease. And oftentimes patients who are in stage 1 and stage 2 are not under the care of nephrologists. But when patients end up with stage 3, 4, or 5, then that's the time that they're usually under the care of a nephrologist. And so that's a term that I'm going to be using in this talk. This other term, UAE, or urine albumin excretion, or essentially how much protein gets into the urine, also has gradations, but there's fewer stages for this. And I'd like to confine my comments to just the blue column, if I may. So one can have a normal amount of albumin in the urine. Everybody has just a tad bit, which is totally perfectly normal. And there's a number for that. It's less than 30 on a typical sample. If the number is between 30 and 300, that's referred to, that's a little bit of protein. That's microalbuminuria. And that's usually can be the first stage of kidney disease, diabetic kidney disease. And if it gets to more than 300, that's macroalbuminuria. So this is a test that nephrologists will often order on patients with diabetes to assess how much kidney disease that they have, because this might show up much earlier than a problem with the serum creatinine or a problem with the glomerular filtration rate. I've put up 2 other designations here. One is a time specimen, which can be for any amount of time, or the very cumbersome 24-hour urine, which I'm sure many of you have had to undergo. Just to let you know, you can get some of the same information from a small urine cup sample that you can from the 24-hour urine for this particular purpose. But it turns out that the numbers work out to be about the same. So in terms of how much protein or how much albumin there is in the urine, there's nothing, a little bit, or a lot. In terms of why kidney disease in diabetics is so important, I mentioned earlier that it is not uncommon at all. It's quite a common thing. Just for some public health data. So about 8% of the United States population has diabetes. Probably fewer than 8% actually know that they have diabetes. But of that, the overwhelming majority are those with type 2 diabetes among adults. And a very small but significant percentage of folks have type 1 diabetes, about 5%. If you then ask, forget the diabetes question for a sec, if you just ask how many patients have chronic kidney disease of some kind, they either have a problem with their filters, they have protein in their urine, or they have a GFR that is below normal, about 15% of the United States population has some form of chronic kidney disease. So we all hear about things like diabetes on CNN, and you don't hear about things like chronic kidney disease on normal mainstream media, but it is actually quite common. And about 1% of this number are the number of patients that are on dialysis in the United States. Right now there's about 300,000, 400,000 people on dialysis in the United States, and about 100-fold times that is the amount of people with chronic kidney disease. Also in terms of patients with kidney disease and who has what cause for their kidney disease, this is data from what's called the United States Renal Data System. Anybody who starts dialysis, that person's nephrologist has to fill out a special form when they initiate dialysis. That form has basic information about demographic and geographic information, but it also has a space to write down the cause of the kidney disease. So the folks at the USRDS aggregate all this data and report it every year. So this is the data from 2010. And what it shows is on the x-axis is the year. So this is 1980, 84, 88, every 4 years up until 2008. And on the y-axis is the rate per million population. So it's basically the number of patients for every million in the population that have any one of the particular causes of kidney disease. This is just the raw number in terms of thousands of patients. And these two graphs are basically similar. And I apologize, it's difficult to see, but this light blue line is for diabetes. So it is the most common cause of dialysis in the United States and actually in the world. And you see here, despite the best efforts of the nephrology community, this number has gone up from 1980 up until 2008, and it continues to go up. I think in the last couple of years it has sort of leveled off just a tad bit, but it has grown immensely over the last 20 to 30 years. The second is high blood pressure, and these other two causes are much more rare than diabetes and hypertension. This translates to about half or a little less than half of all patients who are on dialysis in the United States. The cause of their kidney disease is most likely to be diabetes or diabetic nephropathy. Of all the patients that have type 1 diabetes, about a third go on to develop some form of kidney disease. That doesn't mean that about a third go on to dialysis, but it means that about a third have some form of protein in the urine or some diminution of their glomerular filtration rate or of their kidney function. Thankfully, for the 95% of patients that have type 2 diabetes, this number is significantly lower than that. It's actually about 5 to 10% actually go on to develop overt kidney disease. The one point about this that I want to bring up is that this is a minority of patients. So of all the patients with diabetes, the nephrologist doesn't see everybody that the diabetologist does. It's actually a small minority, especially for type 2, that actually end up developing kidney disease. And this gives those of us in the research field some hope that there is a way that we can figure out what is protecting the other 90 to 95% of patients so that we can apply that to that minority that does get afflicted with kidney disease. And one last point that I don't want to put a damper on the party, but I wanted to bring up because I think it's very important as to why kidney disease is very important to understand and very important to do everything you can to keep it from progressing, is that of the levels of glomerular filtration rate, if you break them down by greater than 60 or into these stages going from stage 3 all the way down to stage 5, and you look at what patients eventually pass away from, and you look at whether they have a CV event or a cardiovascular event. That basically means a heart attack, a stroke, a clot in the leg, and what kind of, how many of those patients actually have to be hospitalized for one thing or another. You see that for all of these three measures, these go up astronomically as kidney disease gets worse. And this is why we have to stay on top of this. This is why we have to try to keep kidney disease from progressing. Because this is independent of everything. This is independent of how many people have diabetes, how many people have high blood pressure, how many people have protein in the urine, how many people have this or that other thing wrong. And so we have to keep a very close eye and really try to slow the progression of the kidney disease with diabetes, because it does result in these other complications of hospitalizations, strokes and heart attacks, and even cardiovascular death. Yes?
You said a minute ago that the fact that the minority of the diabetic patients actually develop kidney disease, that was leading to hope to figure out what the other population was doing right, something like that.
Yes.
Can you expand on that? Have they figured that out?
Unfortunately, that has not been figured out, but I wanted to touch on something at the end of the talk. That's something that we're involved in here, but more importantly might be coming down the pike in terms of new therapy that I'd like to bring up at the end. Yes?
What is BUN?
BUN? So blood urea nitrogen, that's what BUN stands for. It refers to the amount of, it technically refers to the amount of nitrogen that comes from the molecule called urea that's in the blood at any one given time. So it's just a measure of a certain thing in urea. The significance of that is that it often tracks with the creatinine. So if somebody has a high creatinine, they almost assuredly also have a high BUN. There are situations where those two uncouple and that they don't track together, but for the most part, in general, they track together. So we check both, but I really follow the creatinine for, and there's reasons why they might be different. That's why we check both, but for the most part, it's the same story that I was mentioning earlier. As the BUN goes up, that refers to less and less kidney function over time. Yes?
So related to this slide Can the risk of having a heart attack or heart disease be lowered if a patient actually exercises, do a cardio exercise regularly?
So that's an excellent question.
If you could repeat the question.
So the question was, in relation to cardiovascular disease among patients that have diabetes and kidney disease, or just among patients with kidney disease, can exercise actually help to reduce the risk of cardiovascular disease? And the answer is that we actually don't know. And the reason is, I'll tell you the reason is because it's not like nobody's studied exercise and cardiovascular disease. People have been studying that for decades. But in all of those studies, guess which patients they exclude from their analysis? They exclude patients with kidney disease. So it's not very well known. We know patients with kidney disease are less likely to be able to exercise for a variety of reasons, and that patients generally with kidney disease don't exercise as well or don't perform as well on exercise testing as those without kidney disease. But I can't tell you from an intervention standpoint that if you took 100,000 patients with diabetes and kidney disease, or just with kidney disease, and you had them all exercise, you had half of them exercise and you had half of them not do any exercise, the patients that had the exercise would actually do better. The answer to that is I don't know. What I can tell you is that there are things that come from exercise that we have measured more specifically that do help. So for example, weight loss is I'm a big proponent of weight loss because it has been shown that obesity is related to the worsened risk of developing kidney disease, number one. Number two, as you may know, exercise can reduce blood pressure. Number three, exercise can improve sugar control. And number four, exercise can improve cholesterol. So all of those things are, and improving them, are definitely associated with reducing the risk of kidney disease. So whether or not it's the actual exercise or whether it's the fruits of that labor that help is unclear at the moment. In other words, if I gave you a drug to improve your cholesterol, your sugar, and weight loss, would you do just as well if you exercised? Or if I don't know the answer to that. But I can tell you that I often advocate for patients to stay healthy because it helps with everything else, which does affect kidney disease. So this is a very technical slide that will get busy in about 45 seconds. But I wanted to just walk you through what's happening in the kidney when you have diabetes, because I think it's sort of instructive, because this is often a silent disease for a very long time. Until patients find out that they have kidney disease, there's been a lot that's been going on in their kidney for decades. And I wanted to give you some sense of how we understand that. And so here goes. So what's shown on the bottom left is simply a picture of that filter again, just for a point of reference. Blood comes in here, blood goes through this filter, and then enters the urine tube right here. And this is going to be a timeline. So let's say this is year 0, and then at this point is when patients get diagnosed with diabetes. So what happens in the kidney of patients who eventually develop kidney disease, if we were to go back in time? And this has been done because patients have agreed to have kidney biopsies over time from the time that they were diagnosed with diabetes. So we have some sense of this, is that in the first 5 to 10 years after the diagnosis of diabetes, if you were to biopsy the kidney of a patient that eventually ended up with kidney disease 25 to 30 years later, their filter looks totally normal. Don't worry about the technical aspects of this picture, but just to tell you that the filter looks totally normal. The only thing that's going on is actually that their kidney is actually cleaning really well. It's cleaning a little too well, though, is what's happening. And their glomerular filtration rate has gone up as a result of the diabetes. And that's eventually a sign that their kidney is going to poop out later on in time because it's working a little too hard initially. But initially, if you were to measure the serum creatinine, if you were to measure protein in the urine, there would be nothing wrong in that first decade after the onset of diabetes. Yes?
Why is it working too hard?
Why?
Yeah.
It's a good question. It's thought to be directly related to the blood sugar, but it's not known exactly why. There are some theories that part of these blood vessels open up a little bit more, so more blood gets into the kidney, so it has to sort of filter better. But it's not technically, it's not fairly well worked out why that's happening. So then, if you go on to the next decade, after the onset of diabetes, this is between 10 and 20 years of the disease, the patients who had a really high level of glomerular filtration rate actually come back down to normal. So if no one showed up to see a doctor until this time, their glomerular filtration rate, or the kidney, would look perfectly normal if you were to check the blood tests. But in reality, something has gone on because they were doing much better here, and their kidney was working really hard. And then the fact that it's come back down to normal is the first sign that it started to lose some function. And these patients, if you biopsy them, have very minor changes on their kidneys, but they do have the changes that are characteristic of this disease. If you were to go on, during this time, they also develop more and more characteristic changes. And after about 20 years is when patients begin to show some protein in the urine. This is before there's anything wrong with the serum creatinine. And so it's not for 2 decades after the onset of diabetes that this happens. And if you were to biopsy the kidney at this point, you would see some of the irreparable disease that eventually goes on and progresses to full-blown chronic kidney disease. And that can also be accompanied by changes in the blood vessels, which is why patients with diabetes and kidney disease often have problems with high blood pressure that's difficult to control. Eventually, the GFR, the glomerular filtration rate, will be lower than normal for someone of that age, and the serum creatinine will go up. And this is when patients get labeled with chronic kidney disease. But this is years, 20 to 25 years after the onset of diabetes. And we know this information because patients have been followed since the 1940s up near Harvard at the Joslin Diabetes Foundation. And they and others in the country have been following and biopsying these patients for years. And so we now know which patients ended up over here versus which patients had diabetes this whole time and didn't have any kidney problems. And if we can go back and look, this is sort of the natural progression that happens. But the point of this slide is just to understand that it occurs very slowly over a very, very long period of time. And that is why, as a researcher, it's a very difficult disease to get a handle on, because I can't, most things in medicine these days are studied in animals, in small animals, before they're taken to humans. So if there's any drug, if there's any new idea of how to treat a disease, it gets studied in small rodents. But as a researcher, it's not practical to make a rodent diabetic and hold on to it for 20 years to then figure out what's going on 20 years later. So that is why this disease has been very difficult to understand, because it's so slowly progressive over a very long period of time. And I believe you had a question.
Yeah, I didn't quite get, you said something about the high blood pressure relating to the later stages there. I didn't quite get how that related.
So just,
repeat the question?
Yes, so the question is, where does high blood pressure fit into all of this? And the answer is that once patients develop a decrease in their GFR, or glomerular filtration rate, and they develop chronic kidney disease, and they have protein in the urine, this is the time where patients have high blood pressure associated with diabetes. It's possible to have it earlier, but about 90 to 95% of patients will have it certainly by this time.
Is there any relationship then with people who had high blood pressure before the diabetes?
Yes, absolutely, and I'll get into that in just one moment. That's a good segue to the next slide. So don't worry what I mean by KW nodules. Just this is a pathology term for a really severe diabetic kidney. So if you were to biopsy someone who has diabetes and kidney disease, they have these KW nodules. But this is an example of a patient that I think really illustrates the importance of blood pressure in this disease in particular. So this was a case report that was published in 1973, and it was about a patient who had diabetes and had high blood pressure, who died in 1940 of a massive hemorrhage from uncontrolled high blood pressure, intracerebral hemorrhage. And on autopsy, they were found to have a very curious and very rare thing that's helped us to understand this. They had a clot in one of the arteries that went to one of their kidneys. So while both kidneys felt the felt the effects of a high blood sugar, because all of the nutrients and stuff that circulates through their blood was going to both kidneys felt the diabetes, but only one kidney felt the high blood pressure, because one kidney was downstream of a blockage. You can imagine how well water flows behind a dam. It doesn't flow very well. And so if the water flow and the pressure of that water flow is consequential for the disease, then the kidney behind the dam, so to speak, or behind this clot or the stenosis doesn't nearly feel that high blood pressure as much. And then they took those two kidneys, and the one that was behind the clot just had a few changes that were associated with just not getting enough oxygen because it was behind a clot. But it was the other kidney that had massive, massive kidney disease from diabetes. And it reminds me that high blood pressure is the single biggest fuel to this fire. That controlling high blood pressure is of high importance in controlling the progression of the disease. And this is just a case report from 1940, but all the studies that we've ever done on patients with diabetes and kidney disease to see who progresses faster, controlling blood pressure is probably the #1 thing that we can do. And I'll get into how well the blood pressure has to be controlled and with what type of medications towards the end. But this is one of the ways that high blood pressure feeds into this. The other way, based on the gentleman's question, was that there are some patients that come to the attention of a kidney doctor later in life. They might have had diabetes for a couple of years, so they've got diabetes stamped on their medical record. And they, for the first time, have been also stamped with kidney disease. And they might go and see a nephrologist. And someone might try to put 2 and 2 together and say, well, they have diabetes and they have kidney disease. They must have kidney disease because of diabetes, because it's so common and half of patients with kidney disease have diabetes. But in reality, that's not always the case. So there are patients, that same patient might have had high blood pressure for 20 some odd years before they ever had diabetes. And so in that case, that's a very different kettle of fish. That's someone who's had kidney disease from something other than diabetes. They just happen to also have diabetes. So as nephrologists, that has a certain implication because one of those diseases progresses much differently, and it should be treated much differently than the other. So blood pressure plays a role in 2 different ways. Or 3 different ways, rather. Blood pressure is caused by kidney disease, which is what I was talking about on the prior slide, that eventually when you develop this disease, you can have problems with the kidney and then you develop high blood pressure. So it is caused by the disease. In other words, it's a consequence of the disease. It is also something that is responsible for making the disease worse. So one can get into a vicious cycle, you can imagine. And the other is that it might just simply be, it might be in the same patient but not be related to the disease at all. That high blood pressure can cause kidney disease independent of diabetes as well. Yes?
Can you explain a little bit what is the difference in treatment between the 2?
So in both sets of patients, control of the high blood pressure is paramount. Because in both sets of patients, the worse the blood pressure, the worse the kidney disease. But generally, in one of those patient populations, the chance of progressing to dialysis is much faster. Those that have diabetes as their preeminent cause of their kidney disease will progress much faster than those that just have blood pressure as the cause of their kidney disease. Yes?
If the renal artery, the blockage,
yes.
that is removed, when the blood pressure, is there any effect on lowering that blood pressure of that region?
So that's a whole separate thing, but I wouldn't, just to repeat the question. The question is, what is the return on investment of opening up a blockage in the kidney? The answer is that it's a separate question really entirely. It has to do with, first of all, these types of blockages in the kidney are quite rare. And patients that have them have very characteristic clinical features. And oftentimes, as nephrologists, we will send certain tests to look for these type of clots. If we think that a patient is, we're highly suspicious that the patient has one. But 2, importantly, if the patient has clinical signs that suggest that if we did something about it, they would get better. Because not everybody who has clots in their arteries will actually get better by any sort of intervention. It might just be better just to treat their high blood pressure. So this is a very rare thing. Certainly patients with kidney disease and heart disease are more prone to develop these, but it is not in everybody. It's a very rare example that I wanted to bring up just to show the importance of high blood pressure on this disease in general. Yes?
So regarding the comment that you made earlier, I think you said the patient with diabetic kidneys get to end stage where they need dialysis sooner than the patient who have kidney failure due to high blood pressure?
Yes.
Is that correct?
Yes.
So is that correct for patients if both cases have blood pressure under control and also for the patients who actually have their diabetes under control? It's still the patients with the diabetes kidney failure gets to the dialysis faster?
Right. So just to repeat the question, in comparing patients with diabetes and high blood pressure and the progression of their kidney disease versus patients that have high blood pressure as the preeminent cause of their kidney disease who happen to also have diabetes, who progresses faster and who benefits the most from control of the blood pressure? The answer is both sets of patients will benefit from control of the blood pressure. But I guess what you're asking is if everything is equal. In other words, if both of those patients control their blood pressure to the same level and the patient with diabetes also controlled their blood sugar to the same level and everything was the same, generally the patients with diabetes as the cause of their kidney disease will still progress a little faster. But the ceiling is, so that difference is not that much. But the important point is that the ceiling is much different. So if a patient has high blood pressure that is not controlled well, their kidney disease will progress faster. This is in a patient without diabetes. Their kidney disease will progress faster than if they control their blood pressure. But it doesn't, it's not nearly as bad as a patient with diabetes as the cause of their kidney disease who doesn't control their diabetes or their high blood pressure. They will progress even faster. So the real difference between those two is in the patient that doesn't control anything. But in controlling high blood pressure and sugar, the difference between those two groups is much smaller. Yes?
Could you define systolic and diastolic pressures that you consider high?
Yes. So in terms of systolic and diastolic pressures that are what is considered out of control. So I'll have a slide on that later, but a blood pressure of 130, so a systolic less than 130, and a diastolic less than 85 are considered really good. I'll put it. So one might ask, if this disease occurs over the course of 20 to 25 years, and it usually doesn't get diagnosed until 15 to 20 years after the onset of diabetes, is this a reversible disease? And I wanted to bring up that there is some encouraging, tantalizing evidence in patients with type 1 diabetes, but there's not much evidence in patients with type 2. And I just want to bring up this case snippet just to give you a sense of what keeps people like me in the research area hopeful that there's a way that we can control this disease, not just from preventing it from happening, but in patients who actually have it, from reversing the disease. So this is an example of a very rare type of study that's only been published once back about 14 years ago, but it was quite a hopeful sign. So this was about 8 patients. These were a series of patients that had type 1 diabetes. And for whatever reason, their type 1 diabetes was not well controlled. They had a lot of complications from having either low blood sugar or high blood sugar. They were eventually referred for a pancreas transplant and received a pancreas transplant. And these 8 patients were followed at some point after that. So this was done in the 1990s at a time that transplant had a very different outcome and not as good an outcome as now. But these patients were not considered for their pancreas transplant based on any property of their kidneys. So if we then go back and look at their kidneys, these patients actually agreed over time to have kidney biopsies after their pancreas transplant, at the time of their transplant, 5 years later, and 10 years later. So there was no kidney transplant in these patients. They got a pancreas transplant only, but whether they had any kidney disease or whatever small amount of kidney disease they had was followed over time. And this was an example from one young woman who had type 1 diabetes, who'd had it for almost 20 years. So around the time that you'd start to see changes in their kidney if you were to biopsy them. But before they really had clinical signs of kidney disease. And they were biopsied at time 0, the time of their pancreas transplant, 5 years later, and 10 years later. And I'm not a pathologist, none of you have to be to see this anyway, but you can probably appreciate that the amount of dark pink gets less from here to here to here. And if you don't appreciate that based on this slide, 1, I apologize, but 2, don't worry about it. It's all been quantified and reviewed. The amount of kidney disease actually regressed over time. And it was thought that probably because they had a pancreas transplant and pretty much had locked down good control of their sugar over that 10 years, that they were able to actually reverse some of their kidney disease. So in the environment of normal sugar control, this patient and 7 others like her actually had reversal of kidney damage. Yes?
Can I ask you why there was a regression in the type 1 diabetic where there's not really great results for type 2 diabetics?
So the answer is simply that this type of thing had never been done in type 2 diabetics because type 2 diabetics don't get a pancreas transplant. So in terms of screening guidelines, the National Kidney Foundation and the American Diabetes Association have put out screening guidelines for patients with type 1 diabetes and type 2 diabetes to screen for the presence of kidney disease. On that timeline, I showed you that this is a disease that doesn't get diagnosed until later. So we've been sort of hard at work to try to figure out a way to identify patients earlier, to try to slow down the things that make the disease progress and bring that to patients' attention earlier. So patients with type 1 diabetes are often screened starting from about 5 years after their initial diagnosis. And they're screened annually, and some of you may have had this done, with a measurement of the protein, the amount of albumin in their urine, whether they have high blood pressure or not, and what their glomerular filtration rate or their kidney cleaning function is. And if any of these are abnormal, that will put the doctor in a very different position in terms of telling what's going on with this patient, and will prioritize changes in controlling all of this to slow the progression of kidney disease over time. In type 2 diabetics, it's generally recommended that they get checked even from the time that they're initially diagnosed. And the reason is because type 2 diabetes oftentimes probably started about 5 years before it comes to medical attention, because it's often silent for a number of years. But it's the same basic idea that annually patients with type 2 diabetes should be screened for protein in the urine, screened for high blood pressure, and screened for a level of kidney function. And only when any of these things become abnormal are they attuned to the prospect of kidney disease and possibly referral to a nephrologist. In terms of things that are known risk factors for progression to ESRD or end-stage renal disease or dialysis, these are some that I've broken down in terms of factors that lead to type 2 diabetic kidney disease. Many of these are similar for type 1. And I've written down the ones that are ones that we can do something about on the left, and ones that we've identified from studying patients but that we really can't do anything about on the right. On the right are things like genetic factors. And for all of the work that's been done on sequencing the human genome and all of the research studies that have come out over the last 10 years, we do know more about what makes patients with kidney disease progress to dialysis. But unfortunately, none of those studies have ever held true for those with diabetes and kidney disease. So that is still, it's still a mystery. We know that if patients have diabetes and kidney disease in the family, that other patients in the family who have diabetes are at higher risk of developing kidney disease than if nobody else in the family had kidney disease. We know it's familial. We know that from observation, but we don't know exactly why or what part of the chromosome is important for that. We know that parents who have high blood pressure often those patients have a higher risk of them themselves also having high blood pressure and progression of their disease. We know that a low birth weight, curiously enough, is something that will have one progress faster. And we think that's because when the kidneys are developing in the uterus, that, in utero rather, that the kidneys develop, they're one of the last things to develop before birth. And so as these filters and these nephrons are made over time, people who are born early or born premature usually have one less doubling rate of the number of filters. And so if you were born early, you might have less filters than someone born at term. And you can imagine that the fewer filters or cleaning units that you have, the harder each one has to work to do the same cleaning function. And that harder work eventually, that kidney will tire out over time. So it's been shown that that's a risk factor for developing high blood pressure, but it's also a risk factor for developing kidney disease. Male gender, males with kidney disease progress faster to dialysis than females. And there are certain race ethnic populations such as African Americans, Hispanics, and particular Pima Indians that will progress much faster than Caucasians. And there are certain, we and the Palo Alto Medical Foundation are getting ready to publish some data that there are certain Asian ethnicities that are more at risk than other Asian ethnicities. In terms of modifiable disease, these are kind of the 5 things that I try to focus on in clinic. So we know that poor glycemic control or poor blood sugar control is a major known risk factor for progression of the disease. We also know that controlling the blood sugar is a very good way to prevent the disease from happening. So it's not just that we want you to have good blood sugar so that you don't have symptoms of high blood sugar. We want you to have good blood sugar because it prevents your kidneys from progressing fast. As I said, elevated blood pressure is a huge risk factor and has been proven time and time again. High cholesterol is a little bit more controversial, but in general, the better the cholesterol control, the better for progression of kidney disease. Protein in the urine is something that we target as kidney docs. We want patients to have less and less protein in the urine because it is known that the more protein that's in the urine, the faster those patients will progress. And it is still unclear whether it's actually the protein in the urine that's actually somehow bad for the kidney, that if protein gets into the kidney, that it somehow causes damage, or whether it's simply a reflection of how the protein got into the kidney at a damaged filter that is the real culprit. But we do know that the ways that we have to control the amount of protein in the urine could fight either one. So controlling the protein in the urine is a big way that we have to control the progression of the kidney disease. Did you have a question?
Well, yeah, you can probably touch on it later as what are your suggestions for protein control?
Yeah. So I'll get to that for sure. And then the last one is smoking. And patients at risk for heart attacks and strokes, patients with diabetes, patients with high cholesterol, patients with high blood pressure, patients with diabetes are all these patients will be told smoking, will be counted on smoking cessation, but it's also independently been shown for kidney disease that stopping smoking can help to control the progression of the disease. Yes?
I'm sorry, I missed what you said about hyperlipidemia.
Yes, so high cholesterol has been associated with worse progression of kidney disease. So if you take a study of a number of patients, and I don't have the slide up here, but they did this in Denmark with patients who had type 2 kidney disease, and they said, let's control their sugar and their blood pressure and their cholesterol and get them on the right medicine for their protein in the urine and get them all to stop smoking. Will those patients progress slower than patients that don't do any of those things? And the answer is yes. So we know that as a group, this is an effective group. But what I can't tell you is that if everything else is normal, but the only thing that's wrong in a patient's lab profile is their cholesterol, will that solely be enough to make their kidney disease progress faster? That I can't tell you, because that's never been independently studied. But in general, it's the same comment that I had about exercise, that if you control the things that you do to control sugar, diet control, exercise, the things you can do to control blood pressure, the things, those same things help to control cholesterol. So I kind of lump them all together. Sure. So in terms of hard numbers for each of these things, so this is the National Kidney Foundation treatment guidelines for patients with diabetes and with kidney disease, and where we like to have all of their values. So have all of you heard of the term hemoglobin A1C? Yes, for those of you with diabetes, I'm imagining you have. So our goal for patients in terms of what's good glycemic control or good blood pressure control is to have a hemoglobin A1C less than 7.0%. And this is known, and I have a slide on this later on, as to why we target that level. A blood pressure of less than a systolic of 130 and or less than a systolic of 80 is a very good target for blood pressure control. We also know this because if we follow patients who have an average blood pressure that is above that, the higher the blood pressure, the faster their kidney disease will progress. But lower than 130 over 80, there ain't much bang for the buck. So that's why this is sort of the threshold we have for having blood pressure under control. And in terms of what are the best medicines for that, the three types of medicines that we advocate for in general for patients with kidney disease that we want to control their blood pressure to control the progression of their kidney disease is either something called an ACE inhibitor or an ARB. The best way that I remember these is that any medicine, and I don't mean the brand name, I mean the generic name of the medicine, the part in parentheses at the end of that term, anything with a pril, Acupril, lisinopril, benazepril, monopril, enalapril, all of those things are ACE inhibitors. So all of those things sort of target kidney disease in diabetics. Anything that ends in a sartan, so valsartan, candesartan, anything that like that is an ARB. So these are all target the same general area of the kidney, and they're all important for blood pressure. The other very good way to help control blood pressure in a patient with diabetes is they often have a lot of salt retention. And it's one of the reasons that nephrologists will always counsel patients that the best way to control blood pressure is to control what you eat and to control the amount of sodium in the diet. And a water pill, or a salt pill rather, a diuretic, to get rid of excess salt into the urine is a really important way to control blood pressure. And oftentimes we counsel patients to start with one of these two medicines, and then if they're still having problems with blood pressure, to add in a water pill. Yes?
I have a lab work here. I want to ask a question regarding the sodium in the blood.
Yes.
It's low, and I'm assuming, I didn't get a chance to go over this at the ER, that it's because of the water pill I take, and I eat just about 1,000 milligrams of sodium a day. I don't really even like salt. And I was taking the water pill along with the ACE inhibitor.
Mm-hmm.
And, I was wondering if that could be a cause of the low sodium in the blood.
Sure, sure. So the question has to do with the low sodium concentration in the blood in relation to blood pressure to control kidney disease. So do you take something that ends in the word thiazide? Yes. So hydrochlorothiazide is one of the it's the most commonly prescribed medication in the world. It's a medication to control blood pressure that patients who have essential hypertension, whether they have any kidney disease or diabetes or anything else, it's the most commonly prescribed first drug. So it is oftentimes what people start out on for control of blood pressure. Right. And it's also a water pill, so anybody with kidney disease, it kind of helps because we're all about getting rid of the salt and water. And one of the side effects of hydrochlorothiazide is that the serum level of sodium in the blood can go down, especially in patients that do what their doctor says, which is to control the sodium in the diet. And I don't have time to get into why that is and why that doesn't happen with something like Lasix or something like furosemide or Maxide. Well, actually, sorry, it happens with Maxide. But the reason is that, or the solution rather, is that oftentimes people with kidney disease can run into this problem for a couple of different reasons. But the simple solution is to change to a different type of water pill. Because the different type of water pill, like Lasix, is the most common one we use, or torsemide. So it's furosemide or torsemide. Those medications will protect you from developing the low serum sodium. The low sodium in the blood isn't there because you eat little sodium. It's actually something a little bit more complicated than that. But you won't have that abnormal lab if you're on a furosemide or torsemide, and if you stop the hydrochlorothiazide. So that's the main point. It helps to control your blood pressure well, but some patients run into this problem, and then we simply switch. This last point, LDL. LDL is the good kind of cholesterol. The lower the, LDL is the bad kind of cholesterol. I take that back. The lower it is, the better it is for you. So less than 100 is what we target for kidney disease. That's oftentimes not something in addition that you have to worry about just because you have kidney disease, because most patients with diabetes and high blood pressure, their general doc will want to control the LDL to less than 100 anyway. So it's not an additional burden for patients with kidney disease, but it's an additional benefit for patients with kidney disease. In terms of what we do to control the protein in the urine, and we do this even if patients don't have high blood pressure, is we will oftentimes put them on an ACE inhibitor or an ARB, so anything that ends in a pril or a sartan. So you can imagine, I just said that that's good for control of blood pressure. It's also good for control of the protein in the urine. So it's often the first thing we give patients with diabetes and kidney disease because it kills two birds with one stone. It helps control the blood pressure, and it's a better medicine to control the blood pressure than any other kind of medicine because it also helps with the protein. And studies have shown that if you have two patients, one of who control their blood pressure with a pril or a sartan versus another patient that controlled their blood pressure to exactly the same level with a different medication, the one that controlled it with a pril or a sartan will progress less fast than one that controlled with a different type of medication. So our priority is to get the blood pressure down. If it can be brought down with this medicine, all the better. So a BMI of 18 to 25, this stands for body mass index, and this is an index of height to weight. So it's really an index of obesity, and less than 18 is underweight. So we don't like to counsel patients to a BMI less than 18, but generally a goal of a BMI less than between 18 and 25 is what we target. On these general scales, 25 to 30 is considered obese, and 30 and above is considered morbidly obese. And so, I'm sorry, I take that back. 25 to 30 is overweight, 30 to 35 is obese, and 35 and above is morbidly obese. But for kidney disease, we found that the lower your BMI, the better. And so I oftentimes will counsel patients to control their weight. And I think it's a good way because it's sort of an all-in-one. Because patients who control their weight, we know that their sugar gets better. We know that their blood pressure gets better. And we know that their cholesterol gets better. And independently, it makes their kidney disease get better. Yes? Yes? In the urine?
For renal purposes would be best and best assimilated as far as whey versus casein.
Oh, okay. So that is actually not well known, and I am not. I admit that I'm not a very good expert in terms of dietary protein, but what's written here is the recommended daily allowance of protein for a patient with kidney disease, which is 0.8 grams per kilogram per day. So for a 70 kilogram person, that's about 50 to 60 kilograms of protein in a day. The reason I put this up there is not because patients who have more than this, patients who have more than 1.2 kilograms per kilo per day, that have more than 80 or 90 grams of protein a day, that is considered harmful. But it has not been, it's still controversial whether if you lower protein in the diet too much, whether that's a really good thing. But we do know that if the protein in the diet is too high, that's a bad thing. So I put this up as a general ballpark, and I don't think it really matters whether it's whey or casein for the purpose of controlling kidney disease. And I don't think it's very well agreed upon, frankly. But we do know that if you have a very high protein diet, that is bad. But again, many patients with high blood pressure, diabetes, and cholesterol are oftentimes counseled away from eating a lot of red meat anyway. So this is one of those recommendations that I sort of put up on the board as part of the recommendation for kidney disease because it's been shown, but it's probably something you've already been told to do for something else already. And then in terms of what I mentioned earlier about behavioral modifications, smoking cessation, and exercise for the reasons that I mentioned earlier. So just to review, we like to see the hemoglobin A1C, that 3-month variable of how well the sugars be controlled, to less than 7%, a blood pressure of less than 130/80, preferably with something that ends in a pril or a sartan, and if necessary with a water pill, a cholesterol that's lower than 100. Oftentimes these ACE and ARBs have this extra huge benefit of lowering the protein in the urine and also controlling weight and controlling protein intake are just the recommendations of the National Kidney Foundation. Yes?
How often does the National Kidney Foundation adjust the recommendation?
Very rarely. These are from 2006. So it's not something that we adjust very often.
And do they do their own study before they make adjustments?
No, this was by a board of experts that got together, as they were sponsored by the National Kidney Foundation, and got together and considered all the studies that had been done up to that point and provided a number of expert opinion recommendations based on the science that had been done. So it worked. They
But
weren't.
It's not changed often.
No, that is correct. It has not changed often. Yes?
Yeah, I was just curious about the approach that's 0.8 grams per kilogram per day. Should you actually be basing that off of the optimal BMI versus if someone's overweight or obese?
Yes, yes, that is true.
Based on that.
That's true, yes. This slide I wanted to show because I think it's important, and it's also very new. It just came out last year. I had the distinct pleasure of being at the same institution as Dr. DeBoer here. This is a study of patients that had been followed for 20 plus years, that a long time ago in the 1980s were entered into part of a trial where they were told, you have to control your sugar, so your A1C is less than 7. And half of the patients were followed with that control. And then the other group, they didn't care. They said, just do whatever you normally were doing beforehand. Because at that time, 7% was not the goal. And so those patients had an average A1C of about 9.1. So you had two groups that had an average A1C of either 7 or 9.1, which is heretical to think about today, but at the time it was not known that strict a sugar control was important. And these patients had that sugar control for about 10 years. Okay? Then the study stopped. And then they were just left to their own devices with their individual physicians to control their sugar after that. And what turned out is that both groups sort of ended up somewhere in the middle of around a hemoglobin A1C of 7.5 to 8. So both groups after the first 10 years were relatively the same. But for 10 years early on, they controlled their sugar very differently. And the group that controlled their sugar very differently, or very well rather, is the black line here. It was called the intensive diabetes therapy, versus the dotted line, which was the conventional diabetes therapy, which was the convention back in the 1980s. And what's shown on the x-axis is the years since the beginning of the study. So this is when the study started. This is 25 years later, and there was an average of about 22 years of follow-up for every patient. And on the y-axis is the cumulative incidence of impaired GFR, which is to say that how many patients ended up with a GFR less than 60, who way back then were totally normal. And you can see that the patients that intensively controlled their sugar for that first 10 years, after that, the two groups ended up being equal. Those groups still maintained a benefit that was incurred from something they did a long time ago, versus the conventional group who had the same sugar control for the last 12 years as the other group, but had a different sugar control for that first 10 years, had a higher chance of progressing to chronic kidney disease. And this was about a 50% difference. So there was a 1 in 2 chance of, relatively speaking, between the conventional group and the intensive group. So sugar control is a real important part of what we do. And it's not just something that we've observed, that patients who control their sugar better do better. It's actually been shown that if we get patients to control their sugar better, they will do better, period. So it's not just a marker of bad disease. It's actually something that we can mediate and modify and improve the control. So in terms of what's been discovered over this disease, the two biggest things are control of the blood pressure to the level that I recommended, and control of the sugar to the level that we spoke about today. I just wanted to give a brief word on diabetes and transplantation, and I really just put this up there just to round out the talk, not to provide too much new information, but just in the sense that how kidney disease and diabetes intersect in the transplant world. Patients, some of you here, have received a kidney transplant after kidney failure from diabetes. Just for historical reference, when the first transplants were being done in the 50s and 60s, patients with diabetes were actually excluded from the group because they felt that they would not do very well with the transplant because of all the other cardiovascular risks that they had. But since that time, and transplant has gotten better both in technique and in medication for control of rejection, that patients with diabetes now make up a substantial portion of those that are getting kidney transplants. So this is an area which I'm sure you're all familiar with. The other area, which is not as well studied but has been shown to be of benefit, is that there are some patients who have type 1 diabetes and actually have received both a pancreas and a kidney transplant at the same time from the same donor. And that has actually been shown to benefit the patients in terms of how well that new kidney does relative to patients that maintain diabetes but got a kidney transplant. And there's a number of reasons why this could be, but patients who get a kidney and a pancreas at the same time are a much rarer breed. One, you have to be a type 1 diabetic, otherwise it's not helpful. Two, the pancreas transplant is not as well, the outcomes for pancreas transplant are not as good as those for kidney transplant, so there is some inherent risk in pursuing this pathway, and the waiting list is much longer because it has to be from a non-living donor as opposed to a regular kidney transplant, which can be from a living donor. So these are two of the ways that patients with diabetes will go in terms of the way of transplant. The third is that patients can develop, and I don't know if that's the case for anybody here, but patients can develop diabetes from getting a kidney transplant. So if you have a kidney transplant from some cause of kidney disease that has nothing to do with diabetes, the medicines that we provide to control the kidney from rejecting can cause diabetes, and they can cause hypertension, and they can cause high cholesterol. So there are side effects of protecting that kidney. Those medicines work very well, but they have some inherent side effects. And this is something that's getting recognized more and more, and we're learning about more and more each day. So you'll probably learn much more about this as time goes on for those of you in the transplant world. Yes?
I've heard that the rate of post-transplant diabetes is as high as 50%. Is that true?
I haven't.
A lot of transplant people who have developed diabetes.
Right. I think of that rate as around 20 to 30%. I'm not sure it's as high as 50%, but it's definitely increasing over time. Definitely.
I have a question.
Yes?
Do those folks, because they're then at a higher risk of developing all of the risk factors for kidney disease, do they ever get kidney disease in their transplanted kidneys?
Yes. Yes. Oh. Yeah. It has been described to happen. It is not common, but it has been described to happen. You mean the diabetic kind of kidney disease? Yeah. Yes. Yes. Yeah. Yes.
From personal experience, it was explained to me that the rejection rate for the kidney and the pancreas, both transplanted at the same time from the same donor, were separate entities. You could lose the kidney but not the pancreas.
That's correct.
You could lose the
yes.
pancreas but not the kidney.
That's correct. So just as a last area, I just wanted to talk about, I've talked about some things that are hopeful, some things that are not very hopeful, and I'd like to talk a little bit more about things that are hopeful in terms of recent advances in diagnosis and treatment. It's only a couple of slides. I'm almost done. So in terms of how we can identify patients, because I said that only a minority of patients develop kidney disease of all the patients in the world that have diabetes. And that if there was some way to know much earlier on than when they developed frank kidney disease, if there was some way for us to know who was going to develop kidney disease so that we could reliably treat them much earlier. Right now, the earliest marker we have is protein in the urine. But if you recall from that timeline, protein in the urine does not show up until the second decade of the disease. Whereas by that time, there is already known described damage inside the kidney. So you can imagine if we know when someone develops diabetes, and we could send a blood test or send a urine test to figure out who is going to develop kidney disease, then we could target that patient much earlier on and hopefully have a much better effect. If you recall from the slide that I showed about the sugar control of sugar, a much better sugar control very early on made a huge difference 20 years down the road. And there might be a better way to control blood pressure and the protein, control blood pressure rather, much earlier on. Instead of having to treat every single patient with diabetes as if they're going to develop kidney disease, if we could know who was going to develop kidney disease, we would have a much more targeted form of therapy. It would also actually make it much easier for companies to develop therapies if they knew which patients to enroll also. So this was something that actually came out of the Joslin Diabetes Center. These folks had serum from patients that they'd followed for 20 or 30 years. So they knew who developed kidney disease. They just went back to the serum from the very beginning, and they started looking for things. And it turns out that inflammation, generalized inflammation, is a big risk factor for kidney disease. And these folks actually measured a chemical that's related to inflammation. They measured two different chemicals that's related to inflammation. And they showed in patients with type 1 diabetes, they also showed in another study of type 2 diabetics that they followed for years, that if they had a high level of one of these inflammatory markers, that the patients with a high level were the ones that went on to develop dialysis, versus patients with a low level did not. And these were patients that at the beginning basically looked the same. So diabetes, no kidney disease, no protein in the urine, no assured reliable marker that they were going to go on to dialysis or they were going to go on to kidney failure. And they were able to separate them based on a marker. Now, I can't tell you that if you treat this level of inflammation way back then that you'd actually make a difference. But at least we have some sense of what to target at a much earlier stage based on things like this. So there are a number of biomarker studies. We're conducting them here at Stanford too, to try to figure out markers for earlier disease. Not necessarily in the hopes of treating them right away, but in the hopes of identifying them so that we can figure out how to treat them best. This last one is about a study that we're excited to be a part of here at Stanford that I think it remains to be seen whether it's going to be a magic bullet for patients with diabetes and kidney disease, but it's something that has come down the pike that has generated a lot of enthusiasm, or I should say cautious optimism. So you've all have heard the term oxidative stress. Probably most of you have heard that term because you've heard of antioxidants. So things like cranberry juice, acacia berry, anything that you get at Jamba Juice, anything that's vitamin C, vitamin E. You might have heard the term that this food or that food is good for you because it's rich in antioxidants. And these have come up because there are a number of diseases that humans get that are due to a high amount of oxidative stress. And forgetting what that means at the molecular level for now, it is something that the doctors in a variety of different fields, even outside of diabetes and kidney disease, have been trying to figure out ways to target because we know it's associated with disease. And a long time ago, and this is just a slide showing that patients with kidney disease have more markers of oxidative stress than those with diabetes alone. But a long time ago, this group called the Micro-Hope Study, and I forget when this is from, I believe they started in the early 1990s. They had patients take vitamin E or placebo. And the reason they had patients take vitamin E was that they got an antioxidant. And so they wanted to compare what happened to those patients over time. And they were more interested in who is going to develop a heart attack or a stroke. But it turns out some of those patients in that big study had diabetes. And so they followed those patients separately. And they showed that of those patients with diabetes, if they compared who went on to develop kidney disease, and the numbers here are not important, believe me when I say that there was no difference. That the patients who got the antioxidants didn't do any better or worse than the patients who didn't get the antioxidants. And it was shown after a long time that things like vitamin E probably are not terribly helpful because they don't work as antioxidants like we need to protect against oxidative stress. But there's been a lot of more recent literature that we've learned from both animal studies and human studies that there are things in our bodies that control oxidative stress, and we have our own defenses in our bodies for controlling it. And there's a new chemical. You might have heard about this one. It's called bardoxolone methyl. It actually works by, there's a particular enzyme in our body that is a early line of defense against oxidative stress. And its role is to tell the body to make proteins that are antioxidant proteins. So natural antioxidants that our body makes, this one protein tells the cell to make more of it. And so it's a protective mechanism. And this protective mechanism is hampered in patients with kidney disease. So this drug helps to unhamper it, if you will, and tell the body to go ahead and make the defenses against oxidative stress. So a study came out last year with patients with diabetes and stage 3 or stage 4 chronic kidney disease. And they followed patients with a placebo, so basically just not a sugar pill because they were diabetics, but just an empty pill, versus a low dose of this medication versus 2 higher doses. And they looked at their glomerular filtration rate and they followed them for a year. And you can see here that the patients who got the empty pill, basically, this is what happened to them over a year. They slowly progressed ever so slightly over the course of that year in conjunction with what is known for patients with diabetes and that level of kidney disease and how fast they progress. But the patients that got the med, their glomerular filtration rate actually went up. And by the end of the study, they actually were doing better than at the beginning. Now, this is still under investigation. We have some patients in the trial for the next phase of this, which is a longer 2-year trial, and seeing if patients you can reduce the number of patients that go on to develop dialysis or go on dialysis of those patients who have stage 4 chronic kidney disease, and there's about 2,000 patients all over the world that are being studied in this trial. Half of them are getting the drug and half of them are getting placebo, so we can try to see who gets what. And the drug does not, it carries some side effects, but I think the exciting thing is that it's something new that has not been tried in patients with kidney disease and has been shown in about 200 folks that it had some benefit. And it's unclear whether it's going to have benefit after that first year. That's why this trial is a 2-year trial. But it's still unclear whether it's going to have benefit 5 and 10 years. But this particular medicine, based on this one trial, I think there's about 12 other companies that are trying to make a medicine very similar to it, because people have sort of seen the writing on the wall and are hopeful that this targeting this antioxidant stuff is going to be important down the road. So there are things that are out there that people are trying and experimenting with to try to help patients with diabetes and kidney disease. There's nothing been definitive yet. I think the best medicines we have are still controlling sugar and controlling blood pressure with either a Pril or an Artan type of drug. That's still the tried and true stuff that we have. And the last time we had any definitive evidence of that was 2001. So it's been about 11 years since we had anything new to add to that list of treatment guidelines, to answer your question about how often that changes. This is one of the first medicines that I think has the chance to make it to that list. And it's been about a decade. So if it does make it, it's great. If it doesn't make it, it's one more thing that's been tried. But it sort of spawned a generation of companies to try to emulate this. So I think that's all I had. Thank you very much for listening, and I'm sorry if I went over time.